covering the stories that impact your life, your town, your state, and your future. This is the Means Report with your host, Brad Means.
Hello, everybody, and welcome once again to the Means Report. We certainly appreciate you spending part of your day with us, where today we're going to talk about a topic that impacts all of us, our health, and the health of the Medical College of Georgia right here in Augusta, to find out how it's doing, how it's expanding. MCG is everywhere now, and we're going to find out what's happening with that and how that expansion has gone and what the future might hold. We'll look at what it takes to recruit and keep med students, certainly, and then doctors. How do we make sure that these bright young minds stay in Georgia and contribute to our overall well-being and make it easy to access them? And of course, we'll wrap up the Means Report, as we always do, with ways that you can stay in touch and help us get great guests like today's guest, the Dean of the Medical College of Georgia, the Executive Vice President of Medical Affairs there. It's Dr. David Hess. No stranger to the Means Report. Dean Hess, thanks so much for coming back. We appreciate you.
Thanks for having me here, Brad.
Well, and it's timely because, as always, you're just days away from delivering the State of MCG report, as you always do, and so I appreciate you giving us a bit of a preview. First, just a couple of general questions. The relationship between MCG and Wellstar is, I think we're a couple of years into that now. How's it going?
Yeah, a year and a half about. It's going very, very well. You know, this year it's been tough. We had a hurricane, a snowstorm that shuts down the hospital, the ambulatory outpatient for a few days. But we implemented Epic. That's the new electronic medical record. That's a big undertaking. So we implemented that starting in November. I'm still trying to learn how to use it.
Yeah, it sounds like it. Like getting a new computer system here at Channel 6, it confuses everybody. What's Epic do?
Well, Epic, the nice thing about Epic is they have it in all the Wellstar hospitals. So now we can see patients, information about patients in all the Wellstar hospitals, the ones in Atlanta and here. It's the most widely used electronic medical record in academic medical centers. So it allows you to retrieve a lot of information. It's very good about tracking information, doing research. That's really why, Governor Kemp funded that, because it really helps you do research. Medical students, faculty, residents, you can research things. Like you could find out, let's say someone in a basic science lab finds out that they think a certain drug may be reducing the risk of cancer. You could actually go through the electronic medical record of Epic, and you could do this locally or nationally and find out if people on that drug have a lower risk of cancer or not. So it's great for research.
How is enrollment doing? I know that, and correct me if I'm wrong, it seems like 300 med students is kind of the sweet spot for MCG. Where do things stand?
About 304, so
All
that's
right.
Good, very good. So we're about the fourth largest medical school in the country by first-year class. So we have 204 of them, 4 years in Augusta, 60 of them in Athens, and this year we started 40. We actually have 41 in Savannah. Mm-hmm. So we have a 4-year Savannah campus. We've had a 2-year Savannah campus for over a decade, but now it's 4-year.
Okay, based on the numbers that you just gave me, it's safe to assume that Augusta is still the main campus, which is what everyone in Augusta wants. Is that true?
It'll always be. In fact, we'll probably increase the size of the Augusta campus here.
Okay, good.
So this is still really the central campus that we have, and always will be. Now we have campuses all over the state. 2-year campuses, Rome, Dalton, we're down in Albany, we're soon going to move into Thomasville, and then we're down in Brunswick. So we're literally in every corner of the state.
Where do your students come from? Is it a pretty diverse mix?
Yeah, 95% from Georgia. They have to be, 95%. It's one of the highest in the country. They come from all over the state, most of them because most of the populations in Atlanta come from the Atlanta area. That's about 55 to 60%. But we have some admission initiatives now to take students from outside of Atlanta and from rural counties. Only about 5% of medical students come from rural counties. In MCG, it's much higher. It's in the teens, but we want to increase that even more.
And so if you are able to do that, will that hopefully lead to more graduates going back home and practicing?
That's the idea. Yeah. You generally go back and practice where you're from. But we also have other initiatives, the 3+ initiative, where students can graduate in 3 years. They have to do their residency in Georgia, and then we pay their tuition for every year they practice in underserved Georgia. And Georgia is underserved in many. We rank 40th in the country, roughly, in physicians per capita. And in specialties, it's even worse.
I know the 3+ pathways have been successful since you all implemented them, but just for the person who says, look, med school's hard enough, how in the world can you speed it up? Are you sacrificing anything, cutting any corners? Is it too much for some students to try to knock that whole thing out in 3 years?
Well, you have to be a special student to be able to do it.
Yeah.
So the credit hours are as much as our old 4-year curriculum. So it's not that you're getting out of anything. It's just more intense. You kind of lose your summers. You don't have as many breaks.
Yep.
And it's just very, very intense. We try to teach our first 2 years, we've compressed to 18 months. You know, when I went to medical school way, way back, and some medical schools still are 2 years. So you spend 2 years preclinical before you see a patient. We've compressed that to 18 months, and our students see patients in the first month of medical school. They're doing telehealth consultations in the first 6 months.
So hopefully these students graduate and they go back home, or they go to our rural areas per the conditions of the +3 pathways. But overall, is Georgia still, by and large, a medically underserved state? I was looking at a graphic from one of your slides that you're going to use in the state of MCG. It seemed like the whole map was just about underserved.
It's true, it is. Outside of a few counties in Atlanta,
Yeah.
most of the state is underserved,
What's
severely
that mean?
so. Well, it really impacts access to physicians, which is one of the determinants of how your health is. There's a lot more to health than seeing physicians, but that's a big problem. And so people have to go a long ways. Now, to address that, we do a lot of telemedicine. We have a new center for telehealth. We're renaming the MCG Center for Digital Health. That's first being released on the Mean Show. Matt
Nice.
Lyon runs that.
Thank you.
And so we go all over. We're in about 25 rural hospitals doing tele-emergency room, tele-critical care, tele-stroke, soon to be tele-OB, because we have such a high maternal mortality rate. So one way we address it is by telemedicine.
Let me ask you to address that when it comes to the difference between telemedicine and the hands-on approach. Are we sacrificing anything when we're looking at our doctor on a screen versus face-to-face?
Oh, I'm sure you are. I mean, it's always better to be there in person if you can, but if you can't be there in person, there's a lot of studies that at least show in telestroke care, you can do it just as well remotely as you can in person. But there are some things where you have to touch, a patient and palpate, an abdomen, or it is much better to be there. But a lot of times you can have aides at the local hospital, at the local clinic do that for you. And you can do tele-ultrasound now, so you can do more and more things remotely.
What about MCG's place on the national scene? And by the way, I do want to talk about telemedicine a little bit later in this show. You've been a pioneer in the area, especially when it comes to stroke care, so I do want to touch on it in a moment. But where do we stand in the national spotlight? Does NIH, National Institutes of Health, still like us? Are we getting our fair share of funding?
Yes, we are. I mean, this year we've gone up to about $72 million of funding.
Wow.
So that was a 20% increase from last year. And the year before, we went up about 17%, 18%. So in the last 2 years, we've gone up about 40%. And we're still going up in the rankings, the national rankings.
Does it matter, and I think I've asked you this before, does it matter who is the president, or do politics in Washington matter when it comes to funding, or you all operate through different channels?
Well, there's bipartisan support for NIH funding. There always has been, going back to World War II when this really started. The NIH was established, and the government at that time decided that they wouldn't do all the research centrally. They would distribute it out to the universities. So the system is a very good system. It really rewards innovation, and everything is peer-reviewed from national experts. And I said there's always been bipartisan support. I think this administration and some people in Congress have questioned something called the indirect rate, so the overhead on a grant. And so they're looking at whether they should reduce the overhead of a grant.
What about your relationship with insurance companies? Is that overall okay, or is it in some areas problematic when it comes to getting paid for the services that you all provide?
Well, it's always a problem because there's a big uninsured population in Georgia, and particularly southern states. So some patients are uninsured, or we also talk about them being underinsured.
Let me ask you one more question before we take a break, and it has to do with your competition for students. When I watch high school graduates try to choose a college, it's a painstaking process. Everyone is competing for them to enroll at their school. Do y'all face that? And who's your biggest competition, if there is one, at MCG?
Well, the good thing is there's such interest in medical school now that we turn away many qualified applicants. So, we're mostly competing with other schools in Georgia. It's kind of I'd say a healthy competition. We like a class, as I said, that comes from all over Georgia. And while, some of the Atlanta kids are really smart and really well qualified, we also like to look at students from other parts of the state. So I think our big initiative is to get more rural, underserved populations into medical school.
What kind of doctors do these kids want to be when they grow up? Is there a specialty that's super popular right now?
Well, orthopedics has always been popular.
Really?
Yeah. I have a son that does orthopedics, so I know firsthand. But orthopedics, the surgical subspecialties, we've had a lot of women interested in surgery. That's really changed. There's more women in medical school than men now. And even in residencies, which were traditionally men, now we have more and more women. So it varies. It's really all over the place. We have some that want to do primary care, family medicine when they enter medical school. Some want to be cardiologists. It's really what they're exposed to. And some completely change their mind 2 and 3 times while they do their rotations.
What about dermatology? You can't see one of those docs for 6 months.
That is another highly competitive one. I left that out, Brad. You're very, very good. So
I'd want to be
orthopedics
that.
and dermatology, yes. And we have a great dermatology department. Dr. Davis is our chair. We formed that department a few years ago, new, because there was so much interest in it.
Yeah.
And so there's a lot of students that want to go into dermatology, more than there are dermatology positions.
Well, y'all are putting out some great doctors, no question about it. I want to talk more about telemedicine, as I mentioned, when we come back and find out how things are going on that frontier, especially now post-pandemic, when the Means Report continues with Dr. David Hess. Stay with us. Welcome back to the Means Report. We are so pleased to have Dr. David Hess, the Dean of the Medical College of Georgia, with us ahead of his annual State of MCG address. And we talked a little bit about the topics that you'll be hitting on during our first segment, Dr. Hess. Now I want to talk about just general medical topics, if we may, beginning with telehealth. Is that an area, telemedicine, that you've seen grow since the pandemic, or did we just really use it during the pandemic because we couldn't leave our homes and now it's fading?
Well, it definitely grew during the pandemic. We didn't have a choice. And some of that was what we call more direct to consumer. Individual patients contacting their doctor, and we still do some of that. It's fallen since the pandemic, but we still do more than we did before the pandemic. The other type of telemedicine is what MCG has done for a long time, and that's go directly to hospitals and clinics and support rural hospitals. And there's some great stories there. Rural hospitals, if you don't have any patients in rural hospitals, they fold.
Yep.
So the idea with ours is not to transfer everybody to MCG. We don't want to do that, or Wellstar and MCG Health, but to keep them in the local hospital and then provide telemedicine follow-up. That way you keep the right patient in the right place. And that's really the key to telemedicine, is you don't want to take them out of the rural hospital, you want to keep them in the rural hospitals.
And so is that a matter of going down and installing the equipment that you need, cameras, internet access, to make sure that all works?
Yeah, and that's all pretty well. That's pretty much a commodity now, the hardware. The bigger issue is the software and the people to do it, right? And have relationships. Everything's relationships in medicine. Yeah. And it's that way still. You have to have nurses down there and physicians you can work with. The hospital CEOs are remarkably helpful to us, and hopefully us to them. So it's a true partnership.
One of the things I've always admired about you is that you're one of those leaders who has done the jobs that the people you're leading do. You've practiced medicine as a neurologist, and so in addition to the administrative side of your life, you understand where these docs are coming from. Can I ask you a few questions about neurology topics?
Sure.
All right, let's start with dementia, something that impacts so many people and their caregivers.
Yeah.
Are we making any progress on that front?
A little bit of progress. The NIH is focused on that, has put a lot of funding into it. We have some new drugs, that they're IV drugs, but they're expensive and they have side effects that can cause swelling in the brain. So I think this is the first stage. We have to do much, much more. We got to prevent it. We got to really learn how to prevent it better. At our place, John Morgan leads our local memory disorder clinic, which is actually funded by the Department of Public Health. It's a statewide Alzheimer's network led by Emory. We're included. There's one in Savannah, Macon, a few other places. So that's a network where family doctors, family physicians can send a patient in consultation, get a consultation back, and then follow up with them. So that's a great network we have in Georgia. But we have a lot more work to do. I think we're having some drugs, and we need some drugs that are not that expensive and don't have side effects.
Right.
That's really what we have to find.
Have we made any progress to slow down the aging process of the brain? Just even by a little bit would be nice.
Yeah, well, the biggest risk factors for dementia are the same risk factors for heart disease and stroke. A lot of it's hypertension, it's inactivity, it's not keeping your mind active. I mean, those things are really, really important. There was a study called the Finger Study, done in Europe, where if you use multiple modalities, you do crossword puzzles, you watch your diet, you start changing to the Mediterranean diet, you exercise. It has an impact, but you got to do all those things. And it's hard for people to change habits. It's hard to get sedentary people, in their 50s and 60s to walk. And the middle age is the key part. You've got to address hypertension and inactivity in middle age to have an effect in later age.
Yeah, I was going to ask you, so that's the time of life. If you haven't already adhered to some of the lifestyle changes that you just mentioned, 50s and 60s, get on it.
Yep.
Okay.
And the most important thing is walk. Just walk. Get a watch and measure your steps and try to walk how many steps you're doing, add 1,000.
Okay.
Or 2,000.
And people ask me these questions because I love to walk. Do you have to walk fast?
No.
Just move.
Even housework and even gardening, and some studies in the United Kingdom show that it really reduces your risk, particularly of heart attack and stroke, and of course cognition follows all of this. So walking is probably the best exercise, and exercise is the best medicine.
I tell you what, this portion of our conversation may be the most important part because it takes so little to make such a huge change. What about stroke? Can we reverse the effects of a stroke? Can we cure somebody from one?
Well, the big advance in stroke first of all, we want to prevent a stroke, but assuming we don't prevent it and somebody comes in with a big stroke, that one of the arteries going to their brain, like the middle cerebral artery, is occluded, so half their brain is at risk. These mechanical interventions where we take a clot out are life-saving. And the number needed to treat on those treatments is like if you treat 4 patients or 3 patients, you can save someone from disability. It's one of the best treatments in medicine in terms of impact. Now, we can only do those in certain hospitals. We can do it at Wellstar MCG Health. We can do it at Piedmont. But you can't do it in a lot of hospitals in Georgia. You have to be a comprehensive stroke center.
When it comes to neurological function, do you still see a lot of patients, treat a lot of patients with spinal cord injuries? Is that still a thing?
Yeah, we do in our trauma center.
Yeah, so that's primarily trauma.
That's mostly trauma.
All right, back to the research that's going on at the medical college and as it pertains to stroke. Are we making strides when it comes to preventing stroke, or is it up to the patient to do all of that? Can we inject somebody or take a pill that makes them not ever have to worry about having a stroke?
Well, it's not quite that simple, but most stroke patients have strokes because of high blood pressure, diabetes, or they have something called atrial fibrillation. And for the people watching this, the risk of atrial fibrillation goes up with age. And a lot of times it's silent. You don't even know you have it. Sometimes you'll feel your heart rate racing. You can feel palpitations, but a lot of times it's silent. So you should always make sure you're following with the doctor to make sure you don't have atrial fibrillation. Because there's a medicine that reduces your risk of stroke by 80% if you take it, if you have atrial fibrillation. It tends to be a blood thinner. And there's a couple of blood thinners that work. But atrial fibrillation, as you get older, becomes a bigger and bigger risk factor. In the meantime, exercise reduces stroke, blood pressure control reduces stroke, Mediterranean diet appears to reduce stroke.
Do you have a lot of patients who come to you, or just a lot of patients who come to doctors in general with a self-diagnosis? Because it seems like you could go on the internet and figure out what's wrong with you.
Yeah,
do you see that?
More and more people do that. Now with AI, it's easier to get a diagnosis.
Yeah, I was going to ask you about that. How reliable is it?
Well, it's getting more and more reliable. I wouldn't count on, a bot just yet to make your diagnosis, because it helps for a physician to see you. We talk about augmented intelligence. AI is best when it's used with a physician that understands the limitations of AI. But some things, and particularly neurological diseases, can be very, very hard to diagnose. So I would recommend You don't diagnose yourself and you don't treat yourself.
Let's kind of break out the crystal ball as we hit the home stretch of our interview and ask what the future holds for medicine and for the Medical College of Georgia. Let's start with MCG. I mentioned during our first segment that it seems like you all are everywhere in Georgia. And really that's the goal because it improves access. Right. Do you think you'll keep expanding? If so, where?
Well, I think we're going to fill up our campuses where we are, and we started a campus at Wellstar in Kennestone. We're going to enlarge that campus. That's the first campus we've had in Atlanta, that MCG's been in Atlanta. That formally opened in January, but we've been having students there since 2016. So this is just kind of a further expansion of that. The next big thing we have to do in Georgia is graduate medical education. So after you go to medical school, all right, you don't know anything, you have to go to medical school. You don't. You have to do a residency, and then you realize how little you know, and you wonder if you even went to medical school. That's what I wondered when I was a resident. Did I even go to medical school? But you have to do a GME program, a residency, and guess where we are? We're 41st in the country in that, so we don't have enough residency slots. So the state is looking at creating more residency slots. The federal government has awarded us more residency slots in surgery, OBGYN, and psychiatry, because this is a national problem, and it's a complicated problem.
What about the future of medicine itself? We've talked so much about the digital components that remain at the forefront, even post-pandemic. Are we going to see more of that going forward, where we can just streamline the process and maybe every issue doesn't involve a doctor's visit?
Yeah, well, Wellstar is a big proponent of digital health too. That's one of the reasons we merged with them, is they had a big digital health push. Digital health, part of digital health is telemedicine. So doing as many things remote as you can. And then AI in health is really big. You hear about it. Some people are tired of hearing about it, but it's really, really important, the things you can do. We're starting a new department of AI in health. We're doing a national search for a chair, so we'll be recruiting more and more people into AI in health. There's amazing things you can do.
Yeah, it is.
And diagnosis, and just, eventually, right now when you probably go to the doctor, they sit there and type in front of you.
Yep.
Soon now, Epic has this, and there's a little company that works with Epic, Dax Nuance, where if I just talk to you now and I was asking you about your medical history, AI would basically put that history together and create a note, and I would be liberated from my keyboard. I wouldn't have to type anything in, I would just have to edit it. What doctors want is keyboard liberation. That's what I want.
So they can focus more on the person?
Well, the person and the diagnosis and the things that doctors do well, like spend time with the patient rather than spend time typing. I'm a terrible typist.
It's hard.
It's hard.
But Dr. Hess, it's amazing. I'm listening to your answers, and it sounds like you're talking about things that could happen 100 years from now, and they are unfolding as we speak. The technology truly is amazing, and you've been a key player in that, connecting patients to their doctors through telemedicine. So thank you for that, and wow, thank you for being here and informing us about all things MCG. We appreciate it.
Well, thanks for inviting me. I appreciate it, Brad.
We always enjoy our time with Dr. David Hess, Dean of MCG. When we come back, how you can help shape future editions of the Means Report. Stay with us.